My name's Akua, Gyambibi. I'm one of the anesthesia residents. Most people have worked with me or know me, but if not, I'm one of the residents here. I'm in my third year, and I'm doing my grand rounds on the topic of postoperative delirium. So the reason why I chose this topic for grand rounds, before I kind of start to just explain, is I kind of chose it based on experiences over the last couple of years in adult anesthesia, where some of the more difficult interviews or consultations I've had have been with older individuals and their families having concerns about confusion after surgery, or have had experiences in the past themselves being confused after past procedures or past hospitalizations. And a lot of, at the time, my knowledge is not as robust about post-op delirium, so I had a lot of trouble answering those questions. So I decided to pick that for my grand rounds to kind of increase my own knowledge on the topic, and then also learn about some prevention strategies that we might be able to use to try and reduce the incidence of delirium if we can. I think it's an important topic because it is quite common, and it requires recognition that's prompt, as well as prompt management to prevent further complications and maintain patient safety while in hospital. The elderly tend to be most vulnerable to this, and while it certainly is quite costly to the healthcare system in terms of dollars, it's also even more costly to the families themselves or the patients, and it can have some long-term outcomes and reduction of quality of life. So the objectives for today's talk are going to be to define and differentiate postoperative delirium, emergence delirium, and postoperative cognitive dysfunction. Sometimes cognitive dysfunction and delirium are used interchangeably in the literature, but they are different conditions with different ways of measuring them. We're going to highlight the incidence and adverse health outcomes and societal impact of delirium. We're going to look at some risk factors for deterioration after surgery. We're going to discuss some pharmacologic and non-pharmacologic prevention and treatment measures that include intraoperative EEG monitoring and the possible role of preoperative screening to try and identify patients who might be at higher risk. Okay. So just starting with some definitions, postoperative delirium is an acute state of confusion characterized by inattention and a fluctuating disturbance in cognitive function that occurs in the early postoperative period, usually post-op day 1 to 5. And it can be hypo or hyperactive in presentation. In most cases, there's no identifiable single cause for delirium if it's postoperative, other than a history of having a recent procedure, surgery, or anesthesia, and multiple contributing factors might be present. And it can occur in any age group, but is more common in older adults older than age 65. Emergence delirium is immediately after awakening from anesthesia, and it's an intense agitation, disorientation with purposeless movement and inconsolability. And this is usually highest incidence in the pediatric population and associated classically with volatile anesthesia, but it can occur after a TIVA as well. It usually resolves spontaneously within about 30 minutes with no persistent cognition issues or sequelae, as long as the patient is kept from harming themselves or other people. And then finally, postoperative cognitive dysfunction. It's a subtle decline in cognition that's temporally associated with surgery, but the definition is a bit more nebulous. It can affect one or more cognitive domains, but the diagnosis generally rests on whether they've had preoperative testing to determine their baseline level of cognition, and then postoperative testing to determine how much of a change has occurred. And this is a largely reversible phenomenon. Most people have this resolved within 1 year of surgery, but within 3 months, most people are back to their baseline. So we're going to just talk about some of the diagnostic criteria for delirium, and they're based on the DSM-5 criteria, which are just slightly different than the DSM-4, and it includes inattention, as well as the acute change in fluctuating in severity that we kind of mentioned before. And just a disturbance in at least one additional cognitive domain. So that includes either memory, disorientation, perception, hallucinations, and it's not better explained by some other evolving neurocognitive disorder. So that might include severe depression with psychotic features, dementia, or psychosis that can be mimics for delirium. And evidence from history, physical exam, or a lab finding that shows that delirium is attributed to a disturbance in one of those areas. Postoperative delirium is kind of a gray area because usually it has no cause other than the history of having an anesthetic. So anesthesia and surgery may fit into more of a toxin or substance-induced delirium sort of category, but no one actually knows the pathophysiology of delirium at a basic science level, so it's kind of just more of a history of previous surgery. The CAM method is a confusion assessment method, and the CAM ICU method, which is validated in ICU settings, are tools that are commonly used in literature to screen for delirium. So much of the research I'm going to talk about today has used the CAM as a way of detecting delirium postoperatively. This is just an example from AHS and Covenant Health of a CAM screening tool that's used on the wards, and it includes the two main features of inattention and acute fluctuating course, but these are based on DSM-4 criteria, so it includes disorganized thinking and altered level of consciousness, where anything other than alert would be considered possibly suggestive of delirium. So let's talk about the incidence. It varies quite widely with procedure type and with age. In non-cardiac surgery, the range is quite wide, from about 5 to 52%, with increased rates after major procedures such as elective arthroplasty, abdominal, vascular, or thoracic procedures. And from the source that I looked at, which was a systematic review from the American Society of American Geriatric Society, should I say, the highest incidence they found was in hip fractures and aortic surgeries, and obviously a higher incidence in older persons. Cardiac surgery has a high incidence of delirium as well. The overall incidence I found was 32%, but the range again was quite wide, between 33 and 72%. And those studies for cardiac surgery were kind of collected between the 1960s and the mid-1980s. And this particular review kind of looked at that incidence versus incidence in more recent years, and it hasn't really changed over the course of the last few decades. And this slide here just illustrates some of the complex pathophysiology that may be implicated in delirium. So it's very multifactorial, and interactions between the patient's own risk factors, critical illness or a chronic medical illness, the stress of surgery, and medications can lead to a very complex picture. And it's not completely understood, but the implication of reduced cholinergic transmission, just on the bottom left there, is thought to be quite important. Acetylcholine plays an important role in attention, memory, and maintenance of consciousness. Studies have shown that anticholinergic activity has been positively correlated with delirium symptoms, but treatment with cholinesterase inhibitors that boost the levels of acetylcholine have not been seen to prevent or treat delirium in any way. So the pathophysiology is likely more complex than just acetylcholine. Other neurotransmitters such as GABA, glutamate, serotonin, norepinephrine, and dopamine have all been implicated in the pathophysiology, as well as inflammatory mediators such as cytokines, cortisol, and perhaps even brain ischemia. And anesthetic agents tend to potentiate the effects of GABA, so it's not difficult to imagine how they might be associated with the pathophysiology of delirium. And then finally, to consider in older persons especially, would be the effects of polypharmacy, drug interactions, and altered pharmacokinetics and pharmacodynamics of medications. So this slide here is more just to illustrate some of the long-term effects of delirium. No doubt it affects the mental well-being of elderly patients. It puts a lot of stress on their caregivers, but it also can negatively affect other outcomes, such as length of stay in hospital, prolonged ICU stay and intubation, poor wound healing, especially in hypoactive forms, and risk of physical harm due to falls or other injuries in hospital. If anyone can't hear me, can you please let me know to speak up? I'm trying to project as much as I can. The other things associated with delirium that we have to consider would be the costs associated with caring for these patients. So it's estimated that $6.9 billion in Medicare spending in the U.S. in 2004 was attributed to delirium alone. And additionally, increased cost of care up to 1 year post-discharge from hospital have been noted in internal medicine journals. So next, we're going to look at a couple of studies that have shown some of these increased long-term or poor long-term outcomes, including mortality, institutionalization after discharge, and morbidity in elderly patients. So the first study here is a meta-analysis from JAMA from 2010, and it looked at 42 observational studies published between 1981 and 2010. The major findings from this study, this analysis, was that there's a reduced 5-year survival after experiencing delirium in hospital. There's an increased risk of institutionalization. However, they didn't actually mention what institutionalization meant versus a rehab facility or assisted living versus a long-term care facility. And they looked at the incidence of dementia occurring after delirium. They found the follow-up time of most of these studies between 3 months and 5 years, and the median age of all patients included were 65 or older. And they actually went so far as to collect unpublished data from the authors they had approached to try and make sure they got an unbiased look at all the data. Overall, this does highlight the vulnerability of elderly population to the insults of delirium. The first major figure from that study here is the effect of delirium on mortality. And just in the top right, you can see the forest plot there shows an overall trend towards increased mortality. The p-value listed was less than 0.001, and they found the association between mortality and delirium remained significant even when in-hospital mortality was excluded. So even after being discharged from hospital, these patients still had an increased risk of mortality after they'd gone home. This is a survival curve, another figure from the study that shows the trend of mortality over 5 years. And on the x-axis is the period in years, and on the y-axis proportion surviving patients. And they found each circle there represents a study, and the circle size relates to this, the study size or N number. And they found over the course of 5 years there's a stepwise progression of reduced survival. And the confidence intervals are demonstrated by the gray bars there. And then this is the figures for institutionalization. So they found that of 7 studies that were looked at with a total of 2,500 patients, delirium was associated with an increased risk of institutionalization with a p-value of less than 0.01. The mean follow-up was about 14 months. And they looked at this further in a secondary analysis where they separated patients with baseline dementia and patients who did not have dementia and whether delirium affected their rates of institutionalization. And they did find that with dementia patients, it remained significant, but in the non-dementia group, delirium did not have any significant effect on their rates of going to institutions after discharge. And this might just indicate additional frailty or poor functional reserve in patients with dementia who also experience delirium. And then finally, we're going to look at the rates of incident dementia after experiencing an episode of delirium in hospital. So they looked at just 2 studies. It was only 240 patients who were included, and they found a p-value of 0.009 after delirium being related to an increased risk of dementia. And the study here didn't really explain the relationship between dementia and delirium clearly, and it's a very small group of patients, so likely this measure is a little bit underpowered. But overall, I think the study had a strong message showing that delirium is not a benign condition. Even if it resolves, they can still have long-term outcomes that can be quite poor. So this next study here is from the Annals of Surgery, and it looks specifically at patients undergoing major abdominal, thoracic, and vascular surgery who were scheduled for an ICU admission. And these patients were then screened using the CAM-ICU method for delirium. And they looked specifically at incidence, as well as hospital costs, risk of institutionalization, and mortality. Some of the study, it was well done. Only 2 patients were lost to follow-up after 6 months, but it was a very small cohort, and it was 97% men because it was done at a VA hospital. But I don't think anything has shown that the incidence of delirium is different between men and women, so I think the results are probably still valid. So the major figures from this study are on the left, showing the incidence of delirium increasing with age, and the overall incidence they found was 44%. And then over to the right there, we have a table that shows the length of stay in ICU was prolonged, as well as length of stay in hospital overall. The cost of hospitalization was significantly higher in the delirium group. Post-discharge institutionalization was also quite high, and the 6-month and 30-day mortality in the delirium group was significantly higher. What's clear from both of the studies, it kind of shows that the short and long-term outcomes are certainly poorer in people who experience delirium than those who don't. And I think that's something that we don't communicate to patients necessarily as much because it's not a complication that we necessarily see post-operatively on the wards, but I think it's something that we should mention because a lot of data has shown that it's not a benign condition. So next I'm going to talk about some of the risk factors for delirium. And a lot of studies have tried to look for independent risk factors, but no high-level evidence is out there that shows causation between a certain risk factor and delirium. And the most widely accepted model to describe this are predisposing versus precipitating factors. So underlying patient factors that are not usually modifiable are always present, but there are some triggers for delirium that we can maybe have a hand in modifying to try and improve people's outcomes. So this is the major paper on delirium that came out earlier this year from the European Society of Anesthesia, and it was published in February and has a really good, concise review of all of the recent data on this topic. If anyone's interested in the topic, I'd recommend reading that. And it does have some evidence-based recommendations on prevention and treatment as well. So this is adapted from the guideline, and it's just a summary of the risk factors, both preoperative, intraoperative, and postoperative. And the grade A next to the risk factor is a recommendation that's strong with good evidence, and B kind of represents conflicting evidence but an overall favorable outlook. So alcohol use disorders, duration of surgery, and pain were the strongest recommendations. Advanced age was also seen as a favorable recommendation because chronological age might not necessarily communicate how frail a patient might be or their vulnerability to postoperative delirium. Comorbidities were listed as well as ASA status. And the comorbidities that they listed to be most significant were cerebral vascular disease, including prior stroke, Parkinson's disease, cardiovascular disease, depression, chronic pain, diabetes, anxiety, and anemia. Perioperative fasting and dehydration was also noted as a risk factor. Electrolyte derangements such as hypo and hypernatremia, use of anticholinergic drugs, and intraoperative risk factors included duration of surgery, intraoperative bleeding, surgical site, abdominal and thoracic, cardiothoracic being higher risk, and then inadequate management of postoperative pain was also seen as a strong risk factor. Throughout the text, there's other risk factors that have been seen in previous studies, including pre-existing dementia, cognitive impairment, both of which are higher prevalence in older patients, delirium, hearing or visual impairment, malnutrition, including low serum albumin as the marker, reduced functional status and frailty, emergency surgery, hypothermia in the recovery room, and polypharmacy. So with all these risk factors, it's kind of hard to pinpoint one measure that might be able to make a big difference in delirium because it's so multifactorial. But from an anesthetic point of view, there are some things that we can do in terms of treatment and prevention. And what we can't do is remove ourselves completely from the equation, saying this is a post-operative problem. And I think that there's many things we can do within our practice to try and increase awareness about the topic or advocate for other areas of medicine that can be important in treating delirium and preventing complications. So I'm going to go over some evidence for different interventions that can be important in improving outcomes here. So treatment-wise, prompt recognition and treatment of precipitating or underlying causes are very important. To the left is just an example of the broad differential you need to have in mind when dealing with delirium from infection, withdrawal, trauma, hypoxia, endocrinopathies, or any acute vascular injuries. Symptomatic treatment of agitation is only indicated if all other methods fail. So antipsychotics are first line, followed by alpha-2 agonists and benzodiazepines. And finally, physical restraints are a final resort just to prevent harm, but they are actually not indicated, and they actually can precipitate delirium in some patients. Finally, this is multimodal prevention. So these include frequent orientation strategies, which our nurses do a great job of in recovery and on the wards, making sure visual and hearing aids are readily available. So oftentimes I'll see patients come down from their room to have surgery with their hearing aids and glasses out, and who knows how many hours it might be before they return back to their room to have those hearing aids available or visual aids available. So maybe having those those tools available to the patient until they go off to sleep, and then having them immediately at the bedside in recovery room might help to prevent that. Noise reduction and facilitation of sleep. Sleep is something that not many of us get a lot of, especially in the hospital. If we had to stay in the hospital, I can imagine how difficult it would be to sleep with all of the noise and constant activity. But it's something that we have to try and improve, to try and maintain sleep and wake cycles, because disruption of diurnal patterns can be a precipitant of delirium as well. Avoidance of indwelling catheters if not needed, because they pose a risk for urinary retention as well as infection. Early mobilization is important. Optimizing nutrition and hydration status, and adequate pain management is also key to preventing delirium. There was some studies that looked at the importance of fast-tracking surgery, and they were found in hip fracture patients and colorectal patients to make a big difference in terms of postoperative delirium rates from 2 studies from 2011 and 2013. We'll talk a bit more about that later on. Postoperative care pathways for the elderly are programs that are tailored to the needs of hospitalized geriatric patients, and they have been shown to have improved patient outcomes. And these can include things like a geriatric consultation, a joint surgical geriatric unit, or rehabilitation measures. And this is a study by Emer et al., which is actually a surgical resident and part of the surgical department that put out a systematic review on comprehensive geriatric assessment. And they showed an improved 1-year mortality with this intervention and reduced hospital costs, a mean of $3,000 saved per primary admission. A systematic review kind of quoted a number needed to treat as low as 7 to try and improve outcomes with the elderly. And these programs are not, they're quite costly to implement at first, but they can reduce the overall cost attributed to caring for these patients in the long term. This is actually Dr. Kataroo, which is one of these staff who are leading this EASE study, which is an elder-friendly approach to surgical environments. She was happy enough to send me some of the preliminary results, and this study was conducted at the University of Alberta with a control group at the Foothills Medical Center in Calgary. And what they did was implement capacity realignment, which was co-locating all geriatric patients to the same unit in the hospital. And they had interdisciplinary care, including a geriatric consultation. They adhered to evidence-informed practices from NISQIP and ERAS principles. And they instituted a reconditioning or patient-led exercise program and earlier coordinated discharge planning. And this study enrolled about 700 patients, and they just finished, I think they finished enrolling in the spring of this year, and they're just doing their primary analysis now. And they initially showed decreased rates of delirium at this hospital from 25% pre-intervention to 13% post-intervention, p-value of 0.06. And they also found increased geriatric consultation rates and reduced length of stay in hospital by about 2 days, from 10 days to just over 7 days. So in terms of pharmacologic prevention, unfortunately, no single drug has actually been shown to prevent delirium. So I think our focus should mostly be on avoiding drugs that may induce it. So some medication classes to avoid would be anticholinergic drugs, such as antihistamines, Benadryl, Gravol, for example, antimuscarinic drugs if they're not indicated. Opioids are a bit of a tricky topic because untreated pain can also be a precipitant of delirium, and opioids are needed to treat pain. Studies have shown that standard opioids such as morphine, fentanyl, and hydromorphone have no significant difference between them in terms of their risk of causing delirium. But meperidine or Demerol is a standout, as there have been increased risks of delirium associated with using that particular opioid. And as far as they could see, IV versus epidural routes of administration had no effect on the incidence of delirium. Benzodiazepines are associated with an increased risk as well, especially long-acting and high-dose benzodiazepines. And the study that I looked at kind of quoted a high dose as anything being over 5 milligrams of diazepam within 24 hours. And from what I could find in terms of conversion, that would be equivalent to about 1 to 2 milligrams of IV midazolam. And although it can be useful for preoperative anxiety, it may not be appropriate in everyone and may actually put the patient at higher risk of complications down the road. Looking more in depth at benzodiazepines, a Cochrane review was done in 2009, looking at just 3 studies because it hasn't actually been studied extensively in comparison to other medications for treatment of delirium. And this was actually, the studies that were found were actually done in mechanically ventilated patients, AIDS patients, and nursing facility residents, so not necessarily reflective of the population that we might see. But they did find there was no advantage over antipsychotics or dexmedetomidine when benzodiazepines were used, and they found reduced effectiveness and increased adverse effects such as severe sedation or comatose state. The only exception is that benzodiazepines are first-line treatment in any alcohol withdrawal-induced delirium states. Moving on to antipsychotics, haloperidol was seen to be effective in reducing severity and intensity of delirium when it was used, but it did not actually reduce the incidence of delirium in any significant way. And the doses that were suggested based on a Cochrane review showed low-dose haloperidol stepwise from 0.25 milligrams up to 3.5 milligrams total per day. And from what I could see, I had trouble actually finding what the IV equivalent for PO dosing of Haldol was. I was able to contact one of my friends who is a geriatric psychiatry resident, and they typically use 1-to-1 IV to PO dosing. And they found that Parkinsonian adverse effects were higher or more often seen in doses that are greater than 4.5 milligrams per day. There is some preliminary evidence that supports the use of preoperative Haldol to reduce the duration and intensity of delirium in surgical patients. That was seen in 1 study only, and further studies are needed, but that is a promising result because it's something that's easily available to us. You might find a patient who is delirious when they come to hospital or come to the OR, and you may need to treat them with some medication to try to reduce agitation to, allow for appropriate induction or care of the patient. And instead of reaching for midazolam or other benzodiazepines that may be available in the cart, it may be worth going to the Pyxis to get that vial of Haldol instead, because it may actually improve their outcomes. Atypicals include risperidone and olanzapine. They're non-superior to Haldol in terms of treatment of delirium. They're also not available in IV formulation, so they'd only be in oral formulation, so maybe not as useful for us. But they can be considered first-line in patients who require higher doses of Haldol to have an appropriate effect, or people who have contraindications to Haldol use, including Parkinsonism and Lewy body dementia. Other agents that I kind of looked at include ketamine. There's a podcast study that was done in 2017, and there were 672 patients enrolled here that looked at the comparative effect of 0.5 milligrams or 1 milligram of ketamine post-induction versus placebo. And they looked at the risk of delirium afterwards, and they found there was no difference in the incidence of delirium using post-induction ketamine versus placebo. But they did find there's a higher incidence of nightmares and hallucinations in recovery room. And overall, I think one study from 2009 that was, focused on cardiac surgery patients used ketamine and did find a significant difference, but that study result has never been replicated before. So the use of post-induction ketamine for the purpose of preventing delirium is not really supported by the literature. Dexmedetomidine, finally, is a medication that was looked at in ICU patients who were mechanically ventilated. In comparison to propofol and benzodiazepines, dexmedetomidine was shown to have a reduced risk of delirium. Although this is a positive result, it's not necessarily applicable in all surgical patients who may go to an unmonitored ward bed, where some of the side effects of dexmedetomidine, such as hypotension and bradycardia, may not be appropriately monitored. I think there's still some further research to be done in the area of dexmedetomidine because it may be useful. The next question I looked for an answer for was whether anesthetic technique makes any difference at all in the incidence of delirium. And from what I could see, there is no clear benefit of GA over regional with respect to delirium, but some positive results in smaller RCTs have shown that regional nerve block, either fascial Yakka block, 3-in-1 block, or continuous epidural has been shown to have positive results in the hip fracture population. And this is probably due to improved pain control and reduced opioid use. This reduced delirium risk, but some of these studies had serious flaws in methodology, usually due to a small number of patients. They excluded patients who had significant cognitive impairment, didn't provide information on how delirium was diagnosed, and had inadequate blinding. For example, only blinding the participants to the intervention rather than the assessors. So even though this was something that I think is still worth considering, there's some studies that are currently ongoing, such as the Depth HIP study, the EduRapid study, and Mount Sinai study, which I think is going on in Toronto. The EduRapid study is looking at the effect of regional nerve block done in the emergency room by emergency room residents who were trained in ultrasound blocks of the femoral nerve to see if that improves delirium outcomes postoperatively. You might argue that a block done by an anesthetist would be probably of better quality, but I think it's still a worthwhile study, and I'm looking to see what those results might say. And then intraoperative narcotic regimen. So this was mentioned in the guideline as suggested continuous analgesic technique using remifentanil over a bolus-driven technique using fentanyl. And this is a single study with some notable confounders that weren't really addressed. And only one study was really quoted, no other references were given, and it happened to be the same author who was actually writing the 2017 guideline. So I'm not sure what to make of that. Based on that one recommendation, I don't think there's any evidence to change practice. Some of the confounders from that study include there's a fundamental difference between the patient groups that were looked at. Patients who had delirium were significantly older, had a higher ASA status, had longer fasting times and longer surgery times. So I don't know if that's something that's worth changing at this point in terms of narcotic regimen. And then finally, adjunctive anesthesia. Neuromonitoring was recommended to avoid excessive death of anesthesia and reduce risk of delirium. And the next slide here is going to look at a study from 2016 that had showed EEG monitoring was sorry, I need a moment here. So this study looked at EEG monitoring intraoperatively, and it looked at the risk of delirium postoperatively in relation to how burst suppression was measured intraoperatively. So this study is from Anesthesia Analgesia in 2016. It was a cohort study that involved 700 patients. 619 were used in the final analysis, and they looked at patients who received a GA and then planned ICU admission. The protocol was an IV induction followed by maintenance with volatiles, either sevoflurane, isoflurane, or Dazed. The average age of patients included in the study was 62 plus or minus 14 years, and all other characteristics between the two groups were similar. And what they found was overwhelmingly on the left-hand side. The red diagram there shows duration of burst suppression in the bottom axis divided into quartiles, and the incidence of delirium on the y-axis. They monitored EEG with a BIS Quattro sensor, and they calculated suppression ratios from a frontal EEG channel. And the suppression ratio was basically looking back at the last 63 seconds of the operation to figure out what proportion of the EEG was suppressed. And these suppression ratios were added together to give the total duration of EEG suppression for the whole procedure. And then CAM ICU screening was done postoperative day 1 to 5. And they found a significant association between delirium and EEG suppression with a p-value of less than 0.0001, even after adjusting for confounders. And predictors of EEG suppression included a greater end-tidal anesthetic concentration and having received less intraoperative opioids, which may require, obviously, a higher MAC value to maintain adequate conditions for surgery. So the EEG suppression here can be interpreted in one of two ways. The EEG suppression either indicates an excessive depth of anesthesia due to volatile agents, and this is obviously supported by the observation that greater concentrations of volatiles are associated with greater suppression ratios. But another interpretation of the data could be that EEG suppression occurs most commonly in patients who have some preoperative subclinical pathology, so either reduced cognitive reserve, undetected cognitive impairment, early dementia, and these patients may be at higher risk of EEG suppression to begin with. And the paper actually quotes, exposure to anesthesia may serve as a neural stress test, driving patients with subclinical pathology to develop acute confusion after surgery. They also measured on the left-hand side there BIS values correlated with incidence of delirium on the y-axis. The trend was not as clear there, but we do know that burst suppression ratio is part of the algorithm used to calculate the BIS number. And although we don't have the other components of the algorithm because it's proprietary, this study basically shows that EEG suppression and looking at EEG waves can predict postoperative delirium at least as well as BIS values might. And EEG is non-proprietary. It's a free, not free, but it's an easily learned interpretation skill. It can be accessed online or through textbooks, most often freely, to be able to interpret EEG waves. And real-time EEG interpretation may be the most important intraoperative tool that we have to try and affect rates of delirium versus the BIS, which is proprietary, which may not necessarily follow the trend as closely. So my final slide here is looking at preoperative screening and how useful that might be to address some of our concerns regarding the risk factors for delirium. So screening to assess bodily function in a preoperative assessment is normal. Looking at the vital organs are a routine part of any preoperative assessment. But how about screening for cognitive function? It's not something that we do often. And useful data that needs to be collected to assess cognitive impairment can be time-consuming to actually do. You need to have special training to administer and interpret some of these tests. And the time involved in administering a test and interpreting it might not be practical in a high-volume clinic environment. So I looked at a study that tried to assess the practicality of a miniature cognitive screening test. And this is a cross-sectional study that used the mini-cog and the clock-in-box test, which are two tests that were actually developed for primary care settings. Take about 2 to 4 minutes for the patient to complete. And being able to interpret the test results required minimal training and no special equipment or personnel. The mini-cog test is shown to be quite sensitive and specific. Sensitivity is 91% and specificity of 86% to detect cognitive impairment. And screening for undetected cognitive impairment might help us to direct early consultation from geriatrics or postoperative involvement and guide appropriate counseling to the patients regarding their risk of delirium and postoperative cognitive dysfunction. Some of the evidence of clinical benefit of screening alone has not actually been shown, but to kind of think about some of the clinical benefits of screening could be that it could identify patients who might be at increased risk of complications that might have suboptimal outcomes in terms of wound care, rehab, following a complicated medication regimen postoperatively. And screening might benefit patients who might just need more support postoperatively, so that could be organized ahead of time before they're discharged from hospital. It might also help put in perspective the risk-benefit ratio of a supposedly benign procedure for a patient who may be worried about cognitive decline. And for patients who take the test and find that they may have cognitive impairment, who proceed with surgery, it might just make us more vigilant over that patient in terms of monitoring during anesthesia and geriatric consultation. On the other side of the coin, some harm that may come from preoperative screening, it might falsely label someone as impaired, and they may forego an elective surgery for fear of having a poor outcome. And those patients who cognitive impairment is undetected by this test would go through the system and be no better off than anyone else who went for surgery. So does the testing really change any outcomes? Possibly, but I think that needs to be investigated further. Currently, I was able to contact a physician who's a director of geriatric medicine at the university and asked him about what his involvement and his experience has been with preoperative clinic, or pre-admission clinic. And he said that they're very rarely involved in pre-admission consults, but have been involved in post-operative consults from orthopedics in the ACES unit. And as far as they can see, they have had an increase in consultation based on the EASE study, and they have seen positive results being involved in patient care that way. So just a summary of my take-home points from this talk. Delirium is a complex and common condition that is costly to both patients and the healthcare system. And to better manage delirium, we have to have a better understanding of what causes it. And some of the physiological pathways to delirium are not clear, and there may be different subtypes of delirium that have different pathways altogether. So more research is needed into the basic science of the conditions, then we can better translate some of that knowledge into preoperative care for patients at risk. Multiple predisposing and precipitating factors exist, which we went through today. And multimodal prevention is key to maintaining patient safety and preventing further complications. So that includes multidisciplinary care, fast-tracking surgery, orientation, sleep facilitation, sensory impairment must be addressed, etc. Pharmacologically, we can avoid anticholinergic agents, benzodiazepines, and Demerol. Dexmedetomidine might be useful in ICU settings. And as far as residence evidence has shown, there's no role for post-induction ketamine for prevention of delirium. Stepwise low-dose Haldol is preferred treatment, 0.25 milligrams to 3.5 milligrams IV. Considering atypical antipsychotics might be an option in patients who can't receive Haldol. Benzodiazepines for alcohol withdrawal-related delirium. And GA versus regional, there are no clear answers in the literature, but regional blocks may have special utility in hip fracture populations. And then what we just went over now was depth of anesthesia, how neuromonitoring is recommended to avoid deep anesthesia because EEG suppression is associated with delirium. So are there any questions or comments from anyone? I kind of raced through that to try and finish within 45 minutes, but...